Okay, so hi everyone, welcome to today's Study Hub session. Apologies for the tech issues. This is on SBAs for finals, specifically plastics. And we're joined by Dr. Zach, who is going to be taking us through an SBA-led session, which is really exciting. Before we get started, I just wanted to say that if this is your first time on a Study Hub event, or you're relatively new to Study Hub is an amazing medical platform that provides live lectures pretty much every single day, so you don't want to be missing out. And in order to have a look at all of the sessions that we have running, you can use the Study Hub website. You can also follow us on Instagram and Twitter at StudyHubMed to not only have a look at the awesome events that we're running, but also we have snappy SBAs, we have revision tips, all these things to help you guys with your medical education. A few housekeeping rules. This session will be recorded and up on the Study Hub website in about 10 days. And there'll be polls throughout this specific session. So feel free to answer these polls in order to answer the questions. This event will be split into 3 parts with 5-minute breaks in between. Feel free to ask any questions using the Q&A, and let us know, and we'll be able to answer them in those breaks. And at the end of the session, be sure to fill in the feedback form, which if you guys scroll down, if you're viewing this from the site, if not, I'll send a link onto the chat of the Q&A, of the feedback form. And in filling in the feedback form, not only does it help Study Hub, but it helps these awesome educators to know what to do better next time. So without further ado, because we have gone on a bit, I'd like to pass it on to Dr. Zach. Please take it away.
Right, thanks very much, Dana. So hi guys, thank you for joining us. I'm sorry that there was some technical issues at the start of the session, but we'll do best not to overrun. I appreciate that it is a Friday, the weather is nice outside and the pubs are open, so thank you for everyone that's joined us now, and I'm sure some people will be watching this as a recording. So my name's Zach, I'm currently a CT2 plastic surgery, and we'll be starting a plastic surgery registrar job later on this year. And this session, my brief was really just to do some SBAs specifically for plastic surgery. So it's basically, we're just going to have a pure SBA session. We'll go through the answers, why those are the correct ones. We'll talk a little bit about exam technique, and I'll just talk briefly at the end about some of my tips for exam success. So plastic surgery is really one of the surgical specialties that you don't get much exposure to at medical school. So I'm just going to very briefly talk a little bit about the history of plastic surgery. So procedures that we do in plastic surgery have been around for a long time, but really it was during the First World War that plastics as a specialty really took off. And it was this man, and this is Harold Gillies, he's a New Zealander, who during the First World War did a lot of facial reconstruction work because of the way in which it was trench warfare, as I'm sure many of you will know. So it was usually the face of the person that came up over the top of the trench first, and this meant that these soldiers often got quite significant facial injuries. So you can see here this patient has got quite a significant lower face injury to the lower face, and it's been reconstructed. And this is 1914 to 1918 we're talking about here, so it's quite incredible stuff for that time. And Harold Gillies is really one of the founding fathers of plastic surgery. If we move slightly later, so into the Second World War, this is Archibald McIndoe. So he's cousin of Harold Gillies, and he really, again, took plastic surgery on another stride. So particularly with injured airmen. So this is McIndoe's guinea pig club. So pilots were often they were sustaining quite significant facial injuries and facial burns. The fuel tank for the aircraft was behind the control panel, so whenever this was hit, explosion of fire, and these guys had quite significant facial burns. And McIndoe was pioneering in using these tubed pedicled flaps, which you can see here from these members of the Guinea Pig Club, to reconstruct these facial defects. Now, I've just quickly moved to the present day. So this is what kind of plastic surgery we can do as a specialty now. So this is a lady you can see with an amputation of her right arm. and with a little bit of help from our orthopedic colleagues who've done the bony fixation and microvascular techniques here, can give patients a really good outcome that previously was not possible. And you can see this patient at the bottom here actually with a reasonable grip and a reasonable function of her hand. Other things we do are reconstructive operations, so reconstructive operations for cancer, so in this case breast cancer. So the DIEP flap is a very common procedure, and essentially we use that to reconstruct the breast after mastectomy. So you can see here this lady on the left hand side of your picture, she's had a simple mastectomy, so a flat mastectomy, and then on the right hand side you can see this has been reconstructed with a DIEP free tissue transfer, and she's actually had a symmetrizing procedure on the right hand side. The nipple areolar complex you can see here on the left is a tattoo. So that was just a little bit of a brief history about plastic surgery, just to kind of give you a bit of background, because I think it's something that we don't really cover, but it is a really broad specialty, and it covers a lot of body systems, and that's why it's really quite interesting. And the key areas that you guys will need to know for finals or for penultimate year exams will be burns, and so burns pathophysiology and the acute management of burns, wound and tissue healing, and then a little bit about dermatological malignancies. So as I mentioned, this will be an SBA based session. We'll talk a little bit about exam technique. So I put the ask questions throughout the session, so feel free to put questions in the chat and I'll try and answer them at the break. So we'll have 2 breaks. We've got about 20 SBAs to go through, so we'll have a few breaks after the first 7, and then we'll do 5 minutes each time. And there's a few intermittent animated animals around, because I've recently found this function on PowerPoint, so just to keep you entertained on this Friday night. So we'll get started. So first SBA, so it's a 4-year-old child brought to the emergency department by her parents after sustaining a burn to the upper chest. What is the single most likely mechanism of the burn? Okay, fine. So yeah, you can see this 4-year-old with a burn. What's the single most likely mechanism of injury? Okay, so most people have said D, and D is indeed the correct answer, scald. So this is a very common injury to see in pediatric patients. It has the classic pattern of a scald, so the bib pattern, children often pulling things down onto themselves. So this is indeed a scald. Just making sure you can see the SBA, you can see this white screen, SBA 1 now,
yeah,
the answers? Yeah, okay, fine. Yeah, so the causes of children's burns, as you guys have correctly said, this is most likely to be a scald. More than half of causes of children's burns are due to that, and T is the biggest culprit. And if you look at the distribution of adult burns, it's slightly different. So flash and flame burns, scalds are also in there, contact burns. A lot of these are, number one, due to the fact that adults are working and there's work-related hazards, and also adults are doing silly things, essentially. And carelessness and alcohol are the 2 main precipitating factors for burns in adults. So moving on to SBA 2. So this 4-year-old girl had the scald to the upper chest. She was being treated in ED. The burn happened 1 hour ago. She had some wet flannels applied. They used some hydrocolloid burns dressings, which have now been removed. The ED team have put her under cold running water. Approximately how long after the burn is this an effective method for reducing the burn size and severity? Okay, so we've got some answers for B and some answers for C. So the correct answer is C, 3 hours. And so this little bit that you can see at the top here is from the London and South East England Burns Network guidance for initial treatment and management of burns. And you can see that the aim is to complete 20 minutes of calling, and this is effective within the first 3 hours after injuries. And the British Burns Association pushed this 15, 20, 25 statement, which is 15-degree water for 20 minutes reduces the severity of the burn by 25%. There are certain situations in which irrigation for longer periods are more appropriate. So this is, for example, in chemical burns, when you might want to irrigate for up to an hour or until the pH has returned to a normal skin pH level. So moving on, so SBA 3 is a 34-year-old builder brought into ED by HEMS after sustaining a flash burn. Attempting to cut through a gas cylinder with a circular saw when it exploded and caused burns to his abdomen, upper torso and face. C-spine has been immobilised by the HEMS team. On examination, he has a raspy voice, cough, carbonaceous sputum, singed nose hairs. What is the single most appropriate next step? So I'll let you read those. Okay, good. So most people have put E, which is the correct answer. And really, this is a little bit about exam technique as well, because you should always remember that A, B, C, D, E, especially in single best answer questions where a lot of those management options were correct. But really, you need to think about A, B, C, D. What is your first, the first part of that, A for airway? So in this case, you need to be making sure that the airway is safe before moving on and doing anything else. And on the left here, you can see this is the structure of EMSB, which is the Emergency Management of Severe Burns. And this is run by the British Burns Association. This is their little algorithm. So you need to be starting with airway and getting any anaesthetic input early if there's a query or a concern about inhalation injury, which you can, in this case, with this gentleman's symptoms, you'd be concerned for that. Fine, so we'll move on to SBA 4. So I'll just let you read this. Okay, so we've got a little bit of a split here. Most 57% have gone for D, the palm method. The correct answer is A, Jackson's burn model. So all of the other 4 options, so the Wallace's Rule of Nines, London Browder charts, the palm method, and the Mersey Burns app are all appropriate ways in which to determine the total body surface area of the burn. So if you look in this slide on the left-hand side, that is the Rule of Nines. So you can see the body is divided into areas that are either 9% or multiples of 9. So the front of the torso 18%, the back 18%, each arm is 9%, so 4.5% on each side. The legs are 18% each, so 9% on the front, 9% on the back. The head is 9%, and then the final 1% is made up by the perineum. And there's some slight differences for children. You can see the one to the right hand side. So children have big heads compared to their total body surface area. So there's some slight differences for that. In the middle, you can see the London Browder charts, which are a pretty accurate way of telling the total body surface area of the burn. The palm method is a reasonable thing to do. It can be useful for small burns. So a person's palm is approximately 1% total body surface area, and that's the patient's palm, not your palm. And it can also be used to identify areas where there's no burn in large total body surface area burns. And the right hand side here that you can see, the lower right, I don't know whether you can see my cursor, but that's a screenshot from the Mersey Burns app, which you can either get on your phone or you can use on the computer, and essentially just colour in bits of the body and it calculates the burn percentage for you. So none of the methods are perfect, but there are a number of different ways that you can do it. But Jackson's burn model is not one of them. Okay, so just moving to the next question. I'll let you guys read that. Okay, so 86% have gone for A, superficial dermal burn, and that is the correct answer. So blistering is really the hallmark of a superficial dermal burn. Epidermal is pretty much like skin burn, full thickness, not in this case, or deep dermal. Third degree is the same really as a full thickness burn, but we don't really use that terminology. So the differentiating features, you can see that they've divided into superficial, dermal, deep dermal, and full thickness. Sometimes a mid-dermal burn is described. In reality, most burns are of mixed depth. you're very rarely going to come across a burn that is purely one depth, but these are the features that you can look at to help you in identification of the depth. So for superficial, this is red looks like sunburn, as I said. It does blanch, it'll be painful, no blisters, and it will heal without any intervention. Superficial dermal, as the one that we've just described, pink and moist. One of the reasons to de-roof a blister in this case would be to allow you to assess, accurately assess the depth of the burn. It is painful, it does have blisters in it, and then it will heal. So deep dermal, you can see these pictures along the bottom here. The third one along is a deep dermal burn. So mottled whites, cherry reds, fixed staining. It does not blanch. The sensation is dull because you're starting to get damage to the skin appendages that are responsible for sensation. There's no blisters in it, it doesn't heal. It will need surgical input, so debridement and skin grafting. And then full thickness, you can see here. Leathery, brown, insensate, no blistering, and that will also not heal spontaneously. So moving on to the next question, I'll let you guys read this one. Okay, so we've got a bit of a mix here. So half of you have gone for C, some have gone for E. So I can tell you the correct answer is E. So the zone of coagulative necrosis, the zone of stasis, and the zone of hyperemia. And if we look at the burn model here on the left-hand side, you can see that area in the center, the zone of coagulation, where there's the most damage, so the zone of coagulative necrosis, the zone of stasis around the outside of that, and then the zone of hyperemia, again, outside of that. There's sometimes some slightly different terminology for this, but this is the one that you often see. And the way I think about it, and the reason why there's this little how to survive a grenade explosion. Well, firstly, I think it's useful information. Don't get a lot of grenades in tooting, but you never know. But that's the way I like to think about this burn model. So the zone of coagulation, that's close to your grenade, so that's all dead. You can't survive that. The zone of stasis is the area where you've got people that are injured, and quite significantly injured, and they will die if they don't have intervention. And the zone of hyperemia is you're walking wounded, where they're not going to die if you don't intervene. So really the point of that, and the way that helps me to understand, is that the zone of stasis is really where you're aiming your burns management and your initial burns management, your fluid resuscitation. That's the area that you're hoping to try and save. And the issue that you have with this is, so when the burn is about 25%, this zone of hyperemia can really take up the whole of the rest of the body. So we don't count the zone of hyperemia when we're taking into account total body surface area of the burn. So the zone of hyperemia can really take up the rest of the body and cause significant systemic effects. So just move on to the next question. So I'll let you guys read that. Okay, so we've got a little bit of a split here. So all of these things are going to be something that is going to form part of your burns management overall. But this goes back to what we're talking about using your exam technique and thinking about A, B, C, D, E. What is the first thing? What is the most important thing for you to do? And in this case, that's going to be assess the airway. So it's a flash burn, so the chance of an inhalation injury, or there's a potential for inhalation injury, so it's important that you still follow that same algorithm. So burns need to be assessed according to the EMSB and ATLS algorithms, and the first part of that is going to be about an assessment of the airway. So although performing an escherotomy of the arm is a potential, will be something that you will likely need to do, because this arm has vascular compromise, and you're going to need to perform escherotomy to reduce the pressure, it's not the single most appropriate first step, because if this person has an inhalation injury that you miss, that's going to kill them a lot quicker than the fact that their hand is dying because they need an escherotomy. So again, think about your ABCD, think about your structure, and think about your exam technique. On the right hand side here, you can see an example of an escherotomy of the upper limb. So full thickness burns with distal vascular compromise. So in this case, distally, the hand was pale, it was cool, didn't have a capillary refill. A good trick for this is you can put a pulse oximeter on the end of the finger. If the pulse oximeter isn't picking anything up, then there's likely to be vascular compromise. And then you perform escherotomies. So usually this is done in theatre, using diathermy, cutting from areas of unburnt skin to unburnt skin in the mid-axillary lines of the limb. So you can see here on the top coming round, avoiding the ulnar nerve at the elbow and coming down. And this patient has also had escherotomies of the hand. So I think that takes us to the first break. So I think we've got about 5 minutes for guys to go and get something to drink or relax. I don't know whether there's any questions so far. But if there is, please put them in the queue. Zaina, is it in this Q&A or in the chat function? I'm not sure which.
Yeah, Q&A or chat, whatever is easier for anybody. If you guys have any questions, right now we're okay for questions. It's probably because this session is so clear. It's like, it's been a great session so far. And yes, someone said this is so useful to have the session laid out in the way that it is. So it's going great. So yeah, guys, if you, we can meet back in like 5 minutes and then we'll be able to take it to part 2, if that's okay with everybody.
There's a question, I think, here somewhere.
Oh, there is. Oh, what's the use in classifying the zone of necrosis and stasis?
Yeah, so it's a good question. This is more looking at the theoretical, the pathophysiology of burns, rather than it being something that you practically classify in real life. So in a real life burn situation, you'll be assessing the total body surface area, and you won't be including areas of erythema, which, although that's part of the zone to do with in the burn model, this is just looking at the pathophysiology. In practice, you assess the total body surface area of the burn. So anything that's more than superficial dermal, you'll count as that is burn percentage. So if you've got an entire chest, for example, that's going to be 18%, and that's all superficial dermal, that's 18% burn. And it's just so that you're aware that the zone of erythema is significant. And if I had a 25% total body surface area burn, the zone of erythema takes up the rest of my body. So you have a significant physiological reaction to that.
Brilliant. Someone's asked a question more to do with careers. What was it that made you become interested in surgery? I worry that I'll get bored when diagnoses are more clear cut than medicine, but I love procedures and hands-on.
Yeah, so I mean, it's a good question. I think the wonderful thing about medicine is that there's something that to suit everyone's personality. The reason that I chose surgery, I like doing practical things. I think it's interesting. Plastics, I actually ended up becoming interested in as an F2. I did it as a job, and that's often how it works, is you do a job that's interesting, that you have someone, there's a role model, someone you can look up to, someone that makes the topic area interesting, and that's ends up being the specialty that you go into. And the reason why I like plastics personally is that you get a huge variety of procedures that you can do. There's a little bit of medicine in there as well if you do burns management, and you get to operate on young patients, old patients. There's so much variety, and that's really the reason that I chose plastic surgery as a career. But it's whatever suits you. Don't feel like you need to be pressured into a particular career. Just find your own way, find what you're interested in, and just do that.
We've got another question. With the pediatric patient with scald burns, what kind of pain management would you give acute and long term?
So in the acute phase, we usually give IV morphine to these patients, and that will be managed by, if this is a large burn, it will be managed in A&E to start with, and they'll start giving the patient IV morphine usually, but it's part of the analgesic ladder, so they'll get paracetamol and other adjunctive treatment as well, but IV morphine initially, because these burns are particularly painful, and then in the initial stage you may have to assess that, clean the burn. You need to make sure they have adequate analgesia. Someone said, what the burns aspect? With the burns aspects, how bad would the burn have to be in the chest to start worrying? Yeah, good question. Very good question. So someone's asked, with the burns aspect, how bad would the burn have to be in the chest to start worrying about restriction of breathing / movement? So if they have a full thickness burn to the chest, then that can affect your ability, it can affect your chest expansion. So I know we talked about the distal vascular compromise being an indication for escherotomies of the limbs, so inability to ventilate. So this is something that your anaesthetist will be telling you it's difficult to ventilate the patient, will necessitate chest escherotomy. So that's done in a shield-like fashion, so in the mid-axillary line and then under the costal margin, and that allows the whole breast plate to lift up and down and allow the patient to ventilate adequately. And then the second question is, would pain become an issue for respiratory distress as well? Yeah, I think pain management is going to be an important part of, it's important in all of medicine, and making sure that you get on top of these patients' pain early on is key, which is why they give IV morphine usually for pain management for these patients, along with other things. In a pediatric patient as well, it's important to think about the environment in which the child is in, because you want to make sure that it's a calm environment as possible. Play therapists really come in handy with these type of patients. They can really calm the child down, distract them, and that really helps a lot with the pain management as well.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.